A patient arrives in the trauma bay with a catastrophic chest injury, a gunshot wound, a deep stabbing, or severe blunt force trauma. Inside the chest cavity, the body is in physiological freefall. Blood pressure is plummeting as the circulatory system empties. The lungs are collapsing, and the heart is struggling to pump fluid that is no longer there. In these seconds of extreme hemorrhage, the medical team abandons standard surgical preparations. No time to sterilize the skin, no balanced anesthesia, no patient consent. When the monitors show numbers that drop toward zero, the only remaining intervention to halt immediate death is the emergency trauma thoracotomy. Opening the chest initiates a 60-minute countdown. Beyond this 60-minute window, the catastrophic blood loss and the exhaustion of the heart muscle reach a physiological point of no return. Survival depends on manually overriding these systems before the ticking clock runs out completely. The procedure begins with a single, deep incision across the left side of the chest wall. This diagram shows the mechanical force required to access the internal organs. A heavy metal rib spreader is inserted into the incision, prying the bone structure apart to create enough space for a surgeon's hands. To reach the heart in time, the team bypasses standard sterile fields. Reaching the source of the bleeding takes priority over the risk of infection, turning the operating room into a zone of controlled violence. These first 10 minutes are dedicated to brute force access. Surgeons sacrifice the safety of the sterile environment to reach the internal damage before the heart stops forever. Once the ribs are forced open, the surgeon reaches directly into the chest cavity, navigating past the lungs to find the heart and the major blood vessels. This illustrates direct cardiac massage. The surgeon squeezes the ventricles to manually circulate blood. Simultaneously, they apply a vascular clamp to the descending aorta. Halting blood flow to the lower body redirects every remaining drop to the brain and heart. During these 20 minutes, the surgeon functions as the patient's mechanical life support system, manually operating the heart and plumbing to keep the brain alive. As the surgeon maintains the circulation, the rest of the trauma team works to clear the field. The chest cavity is often flooded with blood, obscuring the injuries. The team uses high-volume section to find the source of the hemorrhage. They are looking for torn pulmonary arteries or shredded lung tissue, while simultaneously preventing the patient from drowning in their own blood. This illustration shows the rapid suturing required for trauma repair. Surgeons use heavy thread to patch holes in the heart muscle or the vascular walls, finishing each stitch in seconds. While the surgeon patches the leaks, the perfusionist pumps massive volumes of replacement blood and plasma into the system to offset the ongoing loss. These 20 minutes are a race of fluid dynamics. The surgical team must mechanically repair the structural damage faster than the patient can bleed out. By the 50-minute mark, the repair phase ends. If the intervention is successful, the heart catches its own rhythm and the blood pressure begins to stabilize without manual assistance. The final step is the closure of the chest. This graphic shows how heavy orthopedic wire loops are used to pull the ribs back into place, ensuring the skeletal cage is bound back together. The stabilized patient is transferred to intensive care. Here, mechanical ventilators and vasopressor drugs take over the work of sustaining the body's internal pressure. The thoracotomy remains the most aggressive manual intervention in surgery. It functions as a final attempt to stabilize a patient who has already technically died, relying on physical force when advanced technology can no longer bridge the gap. This 60-minute window provides a fighting chance where none existed before. It is a process that ends either in silence or in the salvage of a human life, bought by the work of hands inside a chest.